So let's get started if we could. And I wanted to tell you that it was very interesting, since our presentation is going to be on quality of life, that I try to keep current, not only doing research, but a couple days before I do a program, I like to go online and just Google what's going on the topics that we're talking about. This one really surprised me because I came into the office on Sunday, yes, I work on Sundays, to do just a very quick Google search on quality of life and what would pop up. And it was interesting that in the Milwaukee Journal-Sentinel, and this is in Milwaukee, Wisconsin, on Sunday, July 25th, the headline under health and fitness was Quality of Life Entering the Gray Area. And I'd like to read this to you for just a second. And if I don't get the names right, forgive me, but I thought this was especially interesting. This is talking, mostly the article was about geriatricians and the shortages that we're going to have, but again, it was about quality of life. And the doctor, forgive me if I say his name wrong, was Duthie. And it says he heads to a nearby room of a 70-year-old. In the world I live in, the doctor says, that's young. Harold Nosebeck bounds out of bed. He's a big man, and he has a big voice. And the patient points to the scars on his body, and he has memories of his past. And he says to him, do you have any chest pain? And he said, I did have some last night. I thought I was going to buy the farm. Quality of life. Do we have a fear of death? Nosebeck may be discharged in a day or two, and the doctor's concerned about him. He wants to make sure he's going to be safe at home. He says to me, and this is Nosebeck talking to the doctor, that he grew up in New York, and to him, a good 24 to 36 ounce porterhouse or ribeye steak would be a light snack. And then the conversation takes a swift turn. Nosebeck talks about how tough it is to survive on a small retirement check. He says he runs out of food before the end of each month. The physician who's sitting by his side is concerned, and he discusses with him how he might enroll in a nutritional program. And he's going to make sure that this patient sees a social worker. And we're going to talk about that with the interdisciplinary team. But he says, you know, that the line that the old age isn't for sissies, the doctor says later, I have a lot of respect for what people are up against. And I think that's what we're going to be talking today, a lot of respect for what people are up against. This article ends on a very interesting note. What the doctor, Duthie, has learned all these years is that patients desire quality of life, not quantity of life. And you're going to see that throughout this presentation today. It's interesting to watch people as you see them in the extremes of life, he says. I don't know a lot of people saying my goal is to be 100. You can do a lot to keep people functioning, and they're very grateful. There's so much he knows, this is the doctor, and so much he does not know, but he keeps striving to keep learning. And that's what we're here for today. We're striving together to keep learning, to be able to talk about and discuss and plan for providing quality of life for seniors and recognizing what our role is. I always think it's interesting when I meet with groups doing this training delivered to you of how many different folks join us. We have family caregivers, healthcare providers, senior centers, guardians, home care agencies, daycare agencies. We have so many folks with so many different needs, but so many things are together for everybody trying to find the same goal to define what it is we can do to provide quality of life for seniors. And so we're excited today to just talk about that because we talk about so many ways around it, but not exactly what it is and defining what it is for people. So when you look at the literature and you start doing the research, the 1940s was the first that I could really find of positive research that was done, and it was done by the World Health Organization. And this study was conducted, and it was indeed just entitled Quality of Life. And out of this study, over all the years that they did this, it said that they're adding years to life, but it was just as important to add life to years. The World Health Organization defined health as this. It's not only the absence of disease and infirmity, but it's also the presence of physical, mental, and social well-being. I thought it was interesting because Sunday, while I'm Googling, I also called my husband on the phone to see what he was up to. And during that time, I said to him, hey, what does quality of life mean to you? And it was interesting that he said to me, it is my general well-being. And so here was the WHO, the World Health Organization, in 1940 talking about a state of physical, mental, and social well-being. And we're going to learn a little bit more about what that means. Quality of life issues have become steadily more important in healthcare and in practice and in research, and we're going to see this as we move away from 1940. We move into the 1970s, and I'm going to tell you it's very interesting. In the 1970s, we began to look a lot more at cost effectiveness and Medicare revisions that stimulated so much research. And why was that? Well, when you think about what some of the things were happening and becoming very prevalent in the 70s, look at all the imaging, the CAT scans, MRIs, prosthesis, transplantation, so much more technology, so much rapid growth in the medical field, and we didn't have the policy and research to keep up with how we were going to afford all this. So decisions were being made when we came to transplantation. What was the risk? What was the benefit? And weighing those risks and benefits. Medical advances forced us to better study what was quality of life. And I thought it was very interesting because in doing some of my background research, I listened to a wonderful lecture by a physician who was saying, it's great when we find perfect pills that make people feel better, but in many cases those pills have an adverse effect that doesn't help them. And we know drugs that can help people with their cognizance, but it also can cause massive diarrhea. And if they don't get to go out and they don't get to spend time with their friends and they're confined to a bathroom, have we improved their quality of life? So lots of research dealt with the physical aspect. We probably will spend very little time on that today, but it's important to know how we got to where we are and what we're studying today for quality of life. So what is quality of life and what are those issues in 2010? We know that individuals continue to age, but the big issue is they're aging longer. Lifespans, and we're not going to get into a lot of statistics, but the lifespans are elongating for people. Normal and pathological, physical, cognitive changes, we know that there are the normal process of aging, but then we also know that there are those that are pathological, and they all affect quality of life. Changing older adult roles is something that was the most interesting to me as I did the study, and I'll be sharing that with you when we talk about grandparenting and some things that have really changed for seniors. And then we know that quality of life also has, not quality of life, but the adding of years to life has the potential to create great sadness and distress in people's lives as well. So when it comes down to the bottom line, people talk about the most effective thing is coping, learning to cope, or many people refer to this as resiliency. The effectiveness coping with changes is often the deciding factor in the quality of life for older adults. Let me just say that again. The effectiveness of being able to cope with changes that occur is the deciding factor in the quality of life for many older adults. And I hope that that's what we're bringing to the table today, and what mmlearn.org does on a continuum is to provide education to help people to cope better, and especially caregivers dealing with these issues. So much more research was done, and what they started doing was developing domains to evaluate quality of life. And anybody who's been involved in research and different things, even if you're in to writing nursing home administrator, continuing education hours, you hear all about domains. Each one of these are important. They may be kind of hard for you to see. You can download this PowerPoint by clicking on the little paper clip in the left-hand corner as well on your screen. But I want you to know that mobility doesn't mean just being able to walk. Mobility can mean transportation from a home to church, transportation to the senior center, expressive communication, being able to talk, receptive communication, being able to hear, all affect quality of life. We could go into so many of these, but we're not. We're only going to focus on 4, but I want you to understand how mammoth this situation is and what we're thinking about. Mood and symptoms. We've all heard about depression, social and interpersonal relations. In just a second, I'm going to show you a very interesting thing through federal regulations in regards to this. One area I'd really like to point out to you is environmental fit. The environmental fit can be that somebody who wants to stay at home gets to. It may be that you're in a nursing home and it's a private room that is your environmental fit, or misfit in many cases. What is an environmental fit, and what kind of a role does it play in quality of life? Gratification and future image. What is your perception of the future? If you think it's never going to get better, or you're never going to be free from pain, or you're never going to see your family again. All of these affect the quality of life, and we won't be able to spend time on all of these, but we're going to focus in on 4 major areas. A lot of the current research, and I think this is so important, has looked at how we're looking at individuals in regards to their cultural backgrounds. We can never leave this out because it changes everything about how somebody relates to grandparenting, to pain, to so many things in their life are culturally inculcated. The different age groups together, the type of disease that you have may affect quality of life, and so much research being done on diabetes, hypertension, socioeconomic status, and educational levels. All affect quality of life. But I think that I have a group that meet with me every month when I do these programs that are with long-term care, and I don't want to leave you out. There's nobody that's not aware of the federal regulations that we must adhere to. This is the size of regulations for a skilled nursing facility. This is profound to me at how we are required to meet these needs. All of these regulations came about because somebody knew this was the right thing to do for people. And every one of these regulations has to do with providing a safe quality of life for individuals who live in nursing homes. If you're from an assisted living, you know that you have your state regulations that are guiding you, and every year those regulations increase. If you're in home care, daycare, respite care, hospice, whatever you're dealing with, you have regulations that are guiding you. And every one of these regulations, if you really look at them and begin to read them, have to do with quality of life. I think it's interesting that if I just pick out one, FTAG 245 is the ability to participate in activities. Those of you like Jerry who are joining us from Florida are running senior centers that I'm sure they're always looking at activities, and are they meeting the needs of the individuals who come and improving their quality of life. Participation in family groups, self-determination, autonomy. There's so many things here that are all involved in quality of life that when we think about our regulatory agencies, we don't really always think about them or relate them back to quality of life issues. So let's get into the meat of what we're going to talk about today. We're going to talk about issues that are affecting the seniors today, their quality of life in 2010. I happen to love the book, and I know I've used it before and pointed it out to you if you've ever been on these programs with us before, on Essentials of Gerontological Nursing. And this was written by Meredith Wallace. Dr. Wallace has done a fabulous job looking at best practices and evidence-based practice for working with seniors. And she highlighted 4 areas that hit me as being exactly right and what are the most important issues that may be affecting us in 2010. Not that all aren't important, but this is really good to hone in on. The first one is elder mistreatment, which deals with the psychological domain of health. We're going to talk about pain, and that's within the physical domain. Spirituality, spiritual domain, and grandparenting, the social domain. And when I first saw grandparenting, I thought, wonder how they fit that in. And it was very interesting to me, and I hope it will be to you as well. So let's start with elder mistreatment. The statistics for elder mistreatment are staggering. And there are hardly any of us that don't hear about this, read about this. This is a major issue in our country and literally across the world. In the United States, there are 1 million reported, now just remember that's reported, events of elder mistreatment. But this is so totally underestimated because of the amount of unreported issues of elder abuse. And why is that? Well, elder abuse in many cases is not reported because there's fear of retaliation. There's fear, if it's a family member, of wanting to protect their family member, or fear that if they report it, they may have to leave their home and be taken away, even from the person who's abusing them, may seem worse to the elder than having to go to a nursing home out of fear. So tremendous underestimation of elder mistreatment in our country. And there's a likelihood that these numbers are going to rise, and we already see this. I don't think it's just likely. I think it's happening. We can relate this to many issues, but one, of course, that's very simple is that our numbers of elder is rising, so is the number of cases of elder mistreatment. So I think there's some important things for us to look at in regard, because we know if somebody is being physically, psychologically, any type of abuse, this is not quality of life. So there are different types of abuse. There's physical and psychological abuse. There's neglect, sexual abuse, and financial abuse. We're not going to get into all of these deeply, but I can tell you throughout mmlearn there are some great programs. Paul Greenwood's program on financial abuse, he's from San Diego, a prosecutor there with the district attorney's office, gives you some wonderful insight into how this affects the quality of life for seniors. Totally changes their life. And yet, when we look at the network that's going on today on the web and how easily it is to take identity, to get into bank accounts, to send people emails, things through the mail, we have to look at all of these. So spend some time on these. But we're going to focus today on neglect, a definition that implies a failure to perform an obligation. Here are the questions of 2010. Are families obligated to care for older adults? Are they? I think this is an important question. And when we started this program, you saw pictures and we talked a little bit about the research today includes issues with the cultural issues that surround a person. Remember, the World Health Organization looked at the entire world in regards to quality of life. Many of the studies today look at quality of life for Hispanics, for black families, for white families. But based on your culture, there may be a different sense of, are we obligated to care for older adults? And if we don't feel that obligation, or we were not prepared for this, does that affect our care for our seniors? There are different types of neglect. There's active physical neglect, which is really purposely withholding care. This is intentionally done without regard for the individual. And I think this is something that we hear about and read about in the papers. But the part that we're not always as knowledgeable about is then being not cognitively or physically capable or trained to provide care as necessary. I'd like to spend a couple moments on this. When you think about who's caring, and that's what this is all about, caregiving and quality of life, who are the caregivers? Many times you're going to find couples, one caring for the other, one who has physical infirmities and the other person who is not cognitively intact. The person taking care of somebody who's not cognitively intact may have their own physical pains, problems getting around. This is a lot what you see in husbands and wives caring for each other as they age up. Are they capable? Are they physically and functionally capable of providing the care that's required? Can they turn that individual if they're bedbound? If they can't, and this person gets a pressure ulcer because of that, do we call them neglectful, or do we call them physically incapable of providing the care? And then for everybody, are we trained to provide the care? And think of all the training that we do for frontline caregivers in skilled nursing facilities and assisted living to provide care. These folks who are at home have never had to learn to make a bed with someone in it, do not understand skin breakdown. So we have to be very supportive of the families that we care for, the people that we are touched by in our practices, whether it's at the physician's office, anywhere. Are we providing the care? And do they have the knowledge to do so? And how are we finding those resources? I hope we're helping you with that, but I hope you're looking for other resources for people that are in your care as well. It's important to understand the characteristics of placing older adults at risk for mistreatment. And before I go into this, let me say at any point you're free to stop me to ask questions. Please send them in. Click on that bubble. Let me know you're watching. And it just helps us to know that we have an audience with us watching. So go ahead and let us know where you're at. And I especially am interested in the field of caregiving that you're involved in. So let's go back. What are the characteristics that place older adults at risk for mistreatment? Well, we know that more females are mistreated than are males. Advanced age, simply that. A functional dependence, an inability to get around on their own, needing help for mobility, and to and from a toilet, all types of functional dependence put them at more risk for mistreatment. A history of intergenerational conflict. Very interesting. So does it mean that we need to do a psychosocial history? It does. Passive or stoic personalities. Interesting. Social isolation. If somebody isn't able to get out of the house and the person who's taking care of them can't get out of the house, we tend to see a higher risk for mistreatment. Cognitive deficits, because the caregiver doesn't understand what's going on, is the most often reason for this. Also, they can't tell someone that they're being abused. And a history of abuse in the family. Now, these are all characteristics that place somebody at risk. So I'm glad to see that we have a number of folks watching us from around Texas. We have somebody from Florida, somebody from Alaska, so this is very exciting. Thank you very much. Caregiver characteristics for potential to abuse. All right, this is a little bit different. Who is the person that is actually inflicting the neglect or the pain on the individual? And always remember, we're talking about quality of life here. Taking away quality of life from seniors. Somebody who has an issue with substance abuse, mental illness, lack of caregiving knowledge or experience, financial stress themselves, puts them under tremendous stress in dealing with the issues with someone who needs their care and attention all the time. If they've had a history of abuse themselves, they're more likely to abuse. Aggressive personalities. Isolation, and this isolation is because they are isolated from their friends and the outside world, maybe had to give up their job to stay home and be the caregiver. And intense life stressors. And these are listed as death in the family. These are listed as divorce. They're listed as loss of a job. So all of these are characteristics that give us the potential to abuse and that we need as professionals to be very cognizant of. And even if we're a family caregiver, we need to know the caregivers that come in to offer respite to us. Do they exhibit any of these characteristics that should make us be watching for the potential for elder abuse and the loss of quality of life for those that we love? What is our responsibility? Well, effectively assessing in healthcare facilities when we have the opportunity to see these families and these people are probably the most important thing. Knowing the signs to look for and reporting to authorities. I want to mention here when we talk about reporting to authorities that the Adult Protective Services is who we would normally report issues of abuse or neglect to. This is an incredible organization. I mean, this is an incredible arm of the government there to support people. But again, they have an incredible workload and they have a lack of resources, and we have to take responsibility for this ourselves as well. So what do we want to look for in those caregivers that may give us indications? Anger or indifference by a caregiver, excessive concern by a caregiver regarding the individual's finances or assets. This is not hard to spot. Lots of questions, not wanting to let mom go to the beauty parlor, wanting all the time to talk about the sister that just wants the money. These all may be things to look for to help us to make sure that we're protecting the quality of life for these individuals. Of course, unexplained bruising and injuries, unexplained dehydration and malnutrition. Poor hygiene comes up very high on the scale of something that we can look for. And above all, an individual who's fearful of the caregiver or, and the one that we tend to miss, overprotective of the caregiver. Again, they may be protecting their granddaughter, their son, because they don't want him to get into trouble, they don't want him in jail, and they don't want to end up in a nursing home, is their thought. So we need to look for all of these signs. There are statutes in all 50 states, but all the reporting is differently. It's done differently. So you have to look at these individually by the state that you're in. And if you have questions, you can contact me always, and just you can use that little bubble again up in the left-hand corner, or you're always free to call us or email us at info@mmlearn.org with questions that you might have about that. The next topic that we're going to talk about is pain, major problem that affects the quality of life of elders. It is not expected that people, because they grow older, should be in pain, and yet think about this, 25 to 50% of people who live out in the community suffer from pain. Nothing compared to the 45 to 80% of nursing home residents that experience and understand this untreated pain. This is not forgivable. This is just for something that I would say that the MDSs are looking at, FTAGs are looking at, surveyors are looking at, and they're in our nursing homes and assisted living looking for this. But who's looking for this in home care agencies, in the adult daycare services? We all have to be aware that quality of life is diminished when someone has pain. We just have to think about that in regards to our own pain to know how it affects us. Well, why do we see this as being so prevalent? Well, pain by some healthcare professional is perceived as a normal part of aging, and this is education. It is not. Individuals may not be able to verbally communicate their issues of pain. Of course, if they're cognitively impaired, that becomes increasingly more the responsibility of those of us who provide the care to know those signs and symptoms. Fear of providing habit-forming medications or addiction. This is something we really have to address. As we've dealt more and more with palliative care, we've learned so much more about the habit formings. And in seniors, this is something that we have to really protect against. And the elder hesitancy to report pain. You might wonder, why do I have a crucifix down in the bottom? Many religious history and growing up was that if we suffer for our pain, we may get into heaven, or that God is giving these crosses to us to bear, and how well do we bear them? And we have to be sensitive to that, and we have to bring in chaplains and social workers to work with people to see how we can help them with other aspects of their spiritual needs, and we're going to talk about that in a minute. But there's entire studies on issues of pain and why people don't report it. But we have to stay on top of making sure that we're going to do something to manage this pain. How do we do that? Well, we have to increase our emphasis on recognizing and treating it. We see that is happening. We see so many more studies on what to do. We have different pain scales. And again, this is an assessment tool that we can use to help people to find what is a tolerable level of pain that does not diminish their quality of life. We can utilize pharmacy consultants. In regulated facilities, we do that all the time. In assisted livings and other areas, we don't. But I can tell you that I've been fascinated with how amenable and helpful pharmacists are, from every place from Walgreens to CVS to H-E-B, wherever you're at, in helping us to understand more. And I tend to call them without hesitancy because they are such a helpful group. Understanding and educating families, staff, and individuals themselves about the negative impact that pain has on quality of life. If you have pain that causes you not to sleep, after a while, the sleep deprivation will have even greater impact. The pain itself will be the deprivation from sleep. I also have to tell you that everything has to be weighed, because when we treat for pain management and we give pains, on the other hand, we may cause constipation. We may cause lethargy. We may cause more opportunities for people to fall because of the fact they're on. So this is a very tenuous situation to work with, but it's one that's well worth it to put the impact and the increased attention on it to improve quality of life for seniors. We have to recognize the value in treating pain on a regular basis and not just PRN as needed. That means that we don't wait for somebody to be in severe pain to medicate, and we have to work with our physicians and families to understand this. Collaborative pain medications using antidepressants, anticonvulsants, and meds for anxiety. We know that people who get shingles have something that sometimes happens called post-herpetic neuralgia. It can be an incapacitating pain that changes people's lives. The quality of life may be that they don't even leave their home because they're so debilitated by this pain. We have found treatments to help these folks, and it is using what we call off-label drugs, or drugs that weren't designed for that purpose but tend to help. We want to learn about this so we can give people back their quality of life in their later years. There are a lot of non-pharmacologic pain interventions, and I think that we're looking more here at holistic issues, massage, acupuncture, arousty, all sorts of things that we have found that may relieve pain, ice packs, heat pads, but we have to weigh all of them and make sure that we're doing everything we can to preserve quality of life. Pain management at end of life is a completely different issue, not totally unrelated, but one that is a topic in and of itself. So I hope that helps a little bit to look at another major area where we're looking at a physiologic domain, pain, for providing quality of life. So we've got a question. It's a great place to stop, and I'll do that. So we have some folks who are watching at the Manor. Thank you very much. We're listening from the Texas Department of Aging and Disability from the Guardianship program. It's wonderful that we have so many people, long-term care, guardianship. I have a question here. It says, my mother lives alone and is able to take care of herself. However, I'm concerned about a grandson who wants to live with her. What would you recommend? I think that this is really important to look at, and maybe when we finish talking about grandparenting and grandchildren, sometimes these turn out to be wonderful situations where parents and children, especially in these economic times, are able to find some mutuality in helping each other. Seniors want to help. They want to continue to have meaning, and we'll see that when we get to spirituality. On the other hand, if it creates a dependency, this person is not providing the care that the senior needs and is beginning to take advantage of the parent, it's going to have to be watched carefully. We have folks watching from Corpus Christi, Homer, Alaska, and Tampa, and many more guardians. So thank you very much for joining us. Continue to send in the questions. I love hearing them from you. Hope I can be helpful. And always know you can contact us at info@mmlearn.org with questions afterwards if we don't answer your questions during this session today. Let's move to grandparenting for just a second. Grandparenting, and I think the important question, is this a new issue about what's happening with grandparenting today and grandparents taking care of their children's children? Well, it's not a new issue. Grandparents have forever raised their children's offspring. That's been a part of life. But I have to say, in our milieu today, in 2010, I don't think the American dream was to raise our children's family. And that's something that may have changed from great-grandparents. Another thing about this being a new issue is people are living longer. I'm 60 years old this year, just turned 60, and I can tell you that I never knew any of my grandparents. They were all deceased before I was even born. So I never had the opportunity to grow up with a grandparent. And yet here I am watching my daughter be with her grandmother, and my niece watching her grandmother become a great-grandmother. So this is more and more common today. And what I want to talk about are, why are more grandparents assuming responsibility for raising their grandchildren? Well, grandchildren are removed from their biological parents today for reasons of abuse and neglect. And why is that? Well, many times we see that as a result of the increased amount of substance abuse that we see in our culture today. We've seen a tremendous rise in teen pregnancy. AIDS wasn't something that I even knew about when I started nursing school about 39 years ago. And the prevalence today of losing a parent to AIDS, both parents to AIDS, may mean that the grandparents are left handling these situations and raising the grandchildren. Incarceration, And incarcerations may be a result of the substance abuse or increased amount of mental illness. The current economic conditions also require many times for families to end up having to live with one another together. The children are out working, and the grandparents are assuming the responsibility for raising the grandchildren. I surely don't want to give the impression, as I present this, that grandparenting isn't something that seniors look forward and don't find meaningful. It's very beneficial for both, for the children and the grandparents. But on the other hand, it can put some phenomenal strains on relationships. The effect on grandparents can be very positive, but it also can show when they are directly responsible for the primary care for these children, higher risk for the health problems in the grandparents, more financial problems and constraints, higher rates of unemployment where a grandparent may have stayed working longer to assure their own ability to retire, have had to retire from their jobs early to stay home and take care of young grandchildren. And this probably the most impressive is the higher rates of stress and depression on the seniors who are doing this. I think that I am amazed with the amount of social support that is required for grandparents dealing with this. And it's interesting that AARP, CDC, your local AAAs are all involved and recognize this as a new era for us, something that is affecting the quality of life for seniors that we need to provide support. In some of the studies I read, they wrote that this was a gap in area of what is provided for people. These are need gaps. And they're beginning to fill these most effectively. I really encourage you to go online. I also say that this is something that we need to bring to the attention of school counselors. And many of them are being made aware of this, and they're already aware because the grandparents are the ones coming in. And some don't even have the guardianship capability. They've not been allowed the legalistic ease to be able to make the decisions for these children. So a lot of support is needed here. I want to share with you for a moment that I was recently out at a university and I was lecturing to a group of nursing students. And I asked this group of nursing students if there was anyone in the room that felt that they would not be dealing with elders when they graduated from nursing school. And several people raised their hands. And so the first one I called on, I asked her what she was going to be doing when she left nursing school. And she said she wanted to work in a neonatal intensive care unit. And we kind of shared for a few minutes that, yes, she might be involved with grandparents for sure, if nothing else to come and enjoy the birth of that new baby. But the next person who raised her hand said that she was already working as an LVN, as a school nurse, and when she graduated from the RN program was going to be taking over a larger position. And she felt she would not be dealing with elders. And when I gave her the statistics on how many people are caring for their grandchildren today in America that will be the primary caregiver there at school and that who she will be dealing with, and they will have multiple comorbidities themselves, issues and stress and depression, that she does have a responsibility, and an emphasis has to be made on learning about dealing with elders and affecting their quality of life just the same as for children. So I think these are all real important points, and I really do thank the author of the book that brought to me the idea of grandparenting. I'm sure those of you who are working in these agencies, and especially with the AAAs and with AARP, that you've developed some amazing programs online. I was so impressed with what's out there to support these grandparents, and now we just need to make sure that we get this information made available to them, because they think they are alone. They're not thinking that everybody else is in this position too. So we move to our final area that we're going to deal with today, the last domain of the spiritual domain, and we're going to talk about spirituality. I think the most amazing thing to me as I went through preparing this program was in the early studies of the 40s, even in the 70s, there was hardly any research done on the quality of life with any attention given to spirituality. And yet, what we do know is that there are so many studies available today that tell us the impact that spirituality has on people's healing, their well-being, their perception of their particular status in life. The cultural differences involved in spirituality are pretty profound, and expressions of spirituality are so increasingly diverse as we have become such a cosmopolitan and our universe is getting so small with the way that we integrate with one another across the divides and the lines of our globe. I'm always amazed at how much work we have to do to learn more about each other, to be able to provide care and to be sensitive to those who are placed in our care. We have to understand that some cultures express their spirituality through religious practices, and others have spiritual practices that are apart from formal religion totally. If we are caregivers, and we are going to talk about quality of life, and we are going to talk about spirituality, I think we have to become far more versed in these cultural differences. Older adults say it is so important to recognize that spirituality represents a search for meaning in their life. And we do know that it becomes even more important as adults approach the end of their life. Not all of us have access when we're in skilled nursing facilities or assisted livings to having a chaplaincy. The facilities that I work with do have an internal chaplain team, and we truly see what a difference they make in these seniors' lives. I want you to think for a second what you're looking at, and you may not be able to see this clearly, but this is the new MDS 3.0 assessment form. MDS 3.0 will come in under the provisions of CMS on October 11th, and we're all going to have to subscribe to it. Every day I open my emails and I see things about MDS 3.0 boot camp, 3.0 new training. But it was fascinating to me. At 38 pages, I could hardly find anything in here other than religious preference, some activities, a few little things in here that address spirituality needs. And yet, think of all the needs assessments that we do. We're doing fall assessments. We're doing skins assessments. We're doing oral assessments. It's unending. I look at the admission packets to come into hospitals and into nursing homes and assisted livings, and it is unending assessments. And yet, I never see a spiritual assessment. Do the tools even exist? Well, they do. Spiritual needs assessment, the resources that are available, I've put two up for you. One is called Stoll's Spiritual Assessment Guide. Another one is O'Brien's Spiritual Assessment Scale. But if we know that this is where people are looking, and if we're aging up, we are nearing the end of our life. If we're looking for meaning for our life, and we're trying to improve the quality of life, and we know this is so essential to people, how can we do this and not have some kind of a spiritual needs assessment or a willingness to spend time to learn what we can do to meet their needs as they're nearing the end of their life, or even if they're still very active at the end of their life, but still wanting to meet and find the meaning of their life. There was a study by Koning that was done in 2007 that said older adults who engage in religious and spiritual practice often cope better psychologically and have better health than those who don't. Does this help with resiliency? And remember, right when we started at the beginning of this presentation, we talked about coping and our ability to cope with what comes along. If spirituality tends to be the thing that has the greatest impact on that, is it anything that we can afford to ignore? I say not. I want to spend a couple minutes and talk about nursing homes. It doesn't matter whether it's assisted living. This can be in adult daycare. I truly understand that most of us are in a position that we have to respect everybody's spiritual beliefs, that we have to look at a cross-cultural section of everybody that we're serving. So we don't want to come in with some religious service that offends one, not another. We have to be so careful. But we talk about individualizing needs. When I started in long-term care, and I came to long-term care from actually being a trauma nurse, I was shocked at some of the ideas of long-term care. I was shocked that you had to ask permission to move somebody from one room to another. I couldn't understand. It took me a while to really understand that this is people's homes. Assisted living are people's homes. So when it comes to individualizing care, and that's where we are today, trying to improve the quality of life, we can have Bible study in the morning. We can have rosaries in the afternoon. I used to object to the fact that we called religious activities activities. I used to think that bingo was the activity, but spirituality was spirituality. That was a church service. I've come to learn in my own life at this age that it is an activity of my life. It's not the same activity as going to the movies or going swimming, but it's a very important part of my life is my spirituality. I think that we have to make this resource available to those who want to say grace before they eat lunch. It doesn't have to be the entire group, but it can be one table, and others might want to join in if it's in an adult daycare or somewhere else. But are we respecting that need on the part of people? In nursing homes, we are beginning to put together a program, and I'm so excited about this, about how to conduct a religious, sort of an ecumenical service for people who are cognitively impaired, 10 minutes or less, that allows people to go back and touch that part of their soul, something in their beginnings, and singing those songs that they remember, saying those prayers that they may not speak but will begin to move their lips to. Are we doing everything that we can for the quality of life for our seniors if we neglect their spiritual needs? I don't think so. The interdisciplinary team is all part of making this happen. We've got to use social service, our chaplains, our activity coordinators, volunteer coordinators, but I just don't think it's an area we can afford to ignore. For some people, they may not want it, and we need to respect that. But for those that do, I think we need to provide it just the same as we do for bingo, and gosh knows we supply bingo. Resources are unending. I will tell you, if you're watching me today on this, you had access to a computer somewhere. You can just start Googling quality of life. I encourage you to go to CDC, AARP, use our resources online at mmlearn.org. But I thought this was interesting, and we've provided these links for you as well. But there is a National Center on Grandparents Raising Grandchildren. Some of the articles and blogs, information on this is just wonderful. So I'm so glad that I can share that with you. Let me just see if I have a couple other questions here before we go to survey and talk about it. How should a caregiver interact with elders' doctors? Should they contact the doctor without the elder's knowledge to give information they know the elder is not sharing? Very interesting question, and one that comes up quite frequently. This question is asking, can I call the doctor and can I share information? What you have to know is you can call the doctor and you can share information, but you need to know as long as that person is competent, the doctor does not have to share back with you. It is building a relationship with the doctor that allows you the opportunity to be able to share that, because he or she is going to want to know that information to provide the best services. You might not get to talk to the doctor. You might be talking to the nurse, and that's just fine too, or a geriatric nurse practitioner. The more information they have, I think the better able they are to treat the patient or the resident. But I think the most important thing to understand is it isn't two-way communication. Because of HIPAA regulations, you may not hear anything back from the doctor, but it just may be something that's there that might plant a seed to allow the doctor to provide better care. I encourage you to do that. There's also some wonderful things on site about what to take to the doctor when you go, what information to have. Sometimes if you have a good discussion with the care receiver as well, they'll be even willing to help you make up the list to take to the doctor so you don't forget to have those things there available for him when you get there, or her. Do you have any religious services online? As a matter of fact, we have new resource on meditation that's online, and there will be religious services coming up online, so that's very exciting, and thank you for asking that question, and that question was from Jennifer, so thank you. It's always important to us to get feedback from you, to know what you think, to know whether these presentations are actually helping you, opening your ideas, minds for discussion among your caregiver peer group, people that you are serving, to ask them questions that help you to better provide for their quality of life. Your feedback is indeed important to us. We look at all these surveys. It takes less than 5 minutes to complete, so I ask you to click on the survey, complete it, and it comes into us, and we'll even be happy to share results with you on different programs. And we'll be doing that in upcoming catalogs as well. We're interested in the negative as well as the positive comments, so don't hesitate either way. We're just trying to make this a better product for all of you. Tomorrow, we're very pleased to be offering Ask the Geriatrician. Dr. Lichtenstein will be joining us and talking about delirium. That's going to be at 10:30 Central Standard Time. I want you to know that if you don't get to watch tomorrow, it'll be uploaded and then placed on demand for you to watch at any time. If you have someone that missed the program today that you've just seen and you'd like to have them see it as well, it'll be uploaded within about a half an hour and available 24 hours a day, 7 days a week. We are so delighted for you to join us. I hope you will take some of these thoughts back, talk about them with your peers, let us know your feedback. Most of all, thank you for joining us. We appreciate it very much. Have a good day.